Hi, Paul.
Hey, Doc.
How are you?
I'm well, thank you.
Good. All right. Can you see my screen, Paul?
I can?
And it's on the first slide?
Yes, it is.
Okay. All right, cool. Let's go ahead and get started. Seems like a smaller group today than we usually have. So we will just jump in for those who are here on time. So I'm Dr. Shauna Springer. I'm joined by Paul Whitmer, an Army veteran and Stella ambassador who is a patient that has been treated at Stella, and he's going to share his story a little bit later. But let's jump in and talk about how we treat trauma at Stella, because it's not the same elsewhere. I've been in the system for many, many years treating trauma survivors of all types, and we have a new approach. And so this webinar is about expressing what that new approach is about, why we, let me turn off my notifications on my phone, why we approach it this way, and Paul will be sharing some of his treatment story. All right. So why this matters. I gave a talk last week to a company about how a lot of people that have trauma go into hiding. And the nature of the condition is that it masks itself from us, even when we suffer. So there are some people who have a hard time really seeing themselves as trauma sufferers. And there are others who see that they are, but still are reluctant to get the help and support they need and deserve. And so these data here on this screen are underestimates of how much PTS, post-traumatic stress, actually has an impact, not only in America, but globally. And I think I don't need to belabor the point that trauma is no longer an abstract concept for many of us after the last 2 years. And to make this relevant to what's happening right now, we have the Ukrainian crisis with Russia, just loads of trauma that didn't exist as of a few months ago. So there's a whole new sector of our globe that have been traumatized by these Russian aggressions, as well as COVID is once again escalating, all over the country. And I was just in a store last night and noticed that once again, everybody was in masks. And it had been a really nice break from that. But now there's like this fear and concern and people talking on phones. And I overheard a conversation with one gentleman who is a contractor with his clients saying, no, I'm going to drop off the stuff and keep my distance because I don't want to risk getting sick to his clients. And so we're back in that whole fear of an invisible virus. Many of us are being thrust back into that. So trauma is something that changes us. It changes how we see the world. COVID has certainly done that for many of us in this country and abroad. And so these figures, as staggering as they are, actually underestimates of how much trauma has impacted us. And there are these myths and misunderstandings that create and maintain so much of the suffering. That Paul, as a combat veteran, is the first one to say, I'm going to mix it up here and call on you here to actually help support this event or help support this point that I'm making, Paul. Would you say, because you have the moral authority to say, as a combat veteran, that PTSD is a veterans issue or only for combat veterans?
I would not. And then just real quick, based on my work as a Stella ambassador, I have probably dealt with 30 prospective clients, and I would say 25 of them were non-veterans. So, when you're in the veteran community, all you see is veterans. But when you break through and you get out and you move around, you can really see that veterans are a small segment of the population.
About 1%. And so when you've spoken to these trauma survivors, did you tell them that you were a combat veteran? Did that come up?
I never really went in depth other than to say I was a veteran. And I asked if they had served. I don't really try and push too hard and get into some sort of comparison, but the people that were veterans did voice that, hey, I'm a veteran. And I never asked if it was combat or non-combat, but for the majority, the vast majority, were civilians.
So within the veteran community, let's go into that a little bit more. Many of the traumas are not related to combat, right?
That's correct. I have dealt with several individuals that were traumatized through MST.
Military sexual trauma. Uh-huh.
Correct. And that seems to be very prevalent among some of our veterans.
What are some of the other traumas that can happen within the military community that have nothing to do with combat traumas?
We have a lot of training exposure, and it's
Yes.
not uncommon to see training accidents that result in injury or
Yes.
loss of life. And I've dealt with several veterans that have been through that type of an experience.
Yep. It's a high hazard occupation. And so the training, as far as it simulates actual conditions, can create, unfortunately, there can be accidents, there can be loss of life, to your point. What about the loss of people you love, like family, to suicide? Can that be a trauma that's not always related to combat?
Of course, and a lot of veterans are getting sort of the secondary hit when it's a friend or a family member that chooses to take their own life, or an individual that was in their unit years ago,
Yep.
and then this individual takes their own life, and now there's a little survivor's guilt and a little trauma mixed in, and it just is a bad brew.
Yep. True or false, many people who serve in the military and people in society in general have childhood trauma.
I would say that's true for sure.
So, one of the things that many of the combat veterans and others who have not served in combat have said to me repeatedly is, yes, I did have some trauma in combat, but that's not the thing that keeps me up at night. It's actually this other thing from childhood, or these sustained traumas I had repeatedly. And so I think looking beyond kind of the obvious story we tell ourselves that, oh, there was a bomb that blew up like in the Hurt Locker and it killed somebody in combat and that's the trauma. A lot of times I think psychologists go on the hunt for that kind of story, as though there's this like narrative, this index trauma, if you will, that caused all of the problems. When in fact, most of the time I found that it actually isn't those things. Sometimes it is, but often it's childhood traumas and the buildup of other things. And one of the things I think it's really important for us to evolve in our understanding is that trauma isn't just caused by the things that we see, things that we could capture on a video, like a bomb exploding, or a training accident, a helicopter crash or something like that. It's also caused by things that we can't see, like years of being neglected by your parents, or the buildup of all these layers of invisible traumas like COVID and how it's changed all of our lives. In whatever part of the country we're in, it's typically had a seismic effect on the way that we live and work, as well as other things like natural disasters. Of course, you can see those on a video, but those often trip a lot of other traumas in terms of, okay, now you've lost your home, who can you count on, right? And then you find out who's really going to be family and friend to you in the aftermath of that kind of event. So trauma is, it's personal, it's individual, it's also well beyond the things that we think of. And it's an interesting thing because it's underappreciated in many cases and it's overused in other cases. Like, it's not a trauma to have to wait through 6 hours at the DMV. It's not fun, but it's typically not a trauma. It's not going to change your assumptions about how safe the world is or whether other people can be trusted. It might even be what you expected when you walked into the DMV. So thinking about, trauma is really important. And part of our desire to innovate comes around wanting to help people understand trauma at a much deeper, more nuanced level. Anything you want to add, Paul, before we move on?
I would just add that in my case, which I can talk about later, but I really didn't have a traumatic event. I didn't really have that
Yeah.
singular intrusive memory to go after. And so it really was a challenge to both me and the clinician.
It would be, because the way that clinicians had been trained, and probably still are trained, honestly, I would imagine, because I was at the VA for 8 years, as you know, Paul, and the way that all of those empirically supported treatments went, we were trained to look for the worst of the trauma, like figure that out, suss it out, and focus on the worst trauma event. And if you can attack that one and help people resolve the emotions and thoughts around that worst event, then the other ones will resolve as well. But many of my patients, to your point, didn't have a single trauma. They had multiple events or an accumulation of events, and the training did not focus on that. So one of the things I want to do is really fill in those gaps and innovate around what trauma actually is for many people when it doesn't fit the narrative that we've been told. And there's a lot of barriers as well, in terms of narratives. You can't talk about a narrative in treatment without talking about the way that these narratives cost people in terms of suffering in silence because of these barriers to care, the reluctance to seek support, the concerns about getting a diagnosis, the feel of going in and being offered medication if that's not something you're interested in. Many of my patients said, don't treat us like a number. We're sort of anticipating that they might be treated as though they were just another patient in a long line of patients in the VA. And so I'm really proud to say that my VA clinic was not like that. And I can't speak for every clinic, but within my clinic, we did some really innovative things, and we had people that really cared, and we had a good team. And so I'm the first to say that there are some really good people in the VA that really care, but that prevalent belief that they would be treated callously or like a number was something I noticed over and over when patients would transfer into my care. A lot of patients will drop out of care. I mean, that is kind of an open secret, that the symptoms will get worse before they get better. And so it's really hard for people to stick with treatment. And I think the solution to that, as we're going to be talking about, is a new model for trauma care, is treating the worst of their biological symptoms first, and then engaging them in talk therapies. Treatment costs time and money as well. And this is where we come to SGB, stellate ganglion block, which is really a game-changing approach, because it brings not just a technique, another tool in the toolbox, as people like to say, but actually a change, a whole kind of philosophical change in the approach to care. And that approach is based on neuroscience-informed innovation and led by the core belief that trauma is not mysterious or invisible. It actually causes a biological injury that is paired with and maintained by changes in how we think and behave, how we navigate relationships, how we see our identities. Paul, I'm going to ask you to jump in, because we have a smaller group, which is kind of fun for me, get to have a little bit more conversation. When I say trauma is a biological injury, let me get your thoughts on that and your response to that different way of seeing it.
I would agree wholeheartedly. I went through I entered the VA system probably in 2008 after my 4th tour overseas, and I didn't really make any progress. The reliance on CPT and PE kind of stagnated me, and I really became disenfranchised with the whole system. But I didn't think that I had sustained any sort of a mental injury. I just couldn't sleep. I couldn't sleep, and my fight flight was turned on, and I didn't feel like I wasn't myself. I didn't feel suicidal or anything like that, but I could tell that something had gone wrong. A blast or something had set me back.
Yep, something was out of whack, and you were working in EOD, Explosive Ordnance Division, right? So having those blast injuries or concussive injuries would have been part of your role. Talk about, some high risk hazard factors in your occupation, but it's sometimes not really the mental challenge of trauma, but strictly a physical shift where you feel it in your body. And a lot of people will say, I was told to go, seek therapy and really, I'm just not sleeping. And then they'll go in and they'll be offered sometimes medications, not just the VA, but other systems will do this too. Medications like Ambien that, can become habit forming, and they're not interested in that treatment plan. And so really addressing the root of the problem, realizing there is a biological shift that's occurred, and addressing that is what this new approach is about in part. So SGB is a precision medicine treatment for an overactivated fight or flight system. And it targets these hyperreactivity symptoms of post-traumatic stress. Things like difficulty sleeping, difficulties concentrating, the startle response, a sense of jitteriness or jumping out of your skin when someone walks up behind you, the sudden surges of panic or irritability, sort of the hair trigger anger reaction that people have, and they say, yeah, that's not really who I am. That's not who I want to be. Those are the target symptoms identified in the research. One of the biggest myths about SGB is that it's a new and fringy treatment. And I'd never heard of it when I was in the VA and learned about it from a special forces medic about 5 years ago now. Many clinicians have never heard of it in the civilian and military sectors, but more of the military clinicians have heard of it. They're more likely to know about it because it's been used primarily in special forces units at Fort Bragg and also in the Army at Tripler Army Medical Center, Walter Reed Medical Center, and Landstuhl in Germany are all treatment sites that have been also part of big research studies. But the procedure has been around for nearly a century. First documented case was in 1926, and it comes out of the pain discipline. It's an anesthesiologist, Dr. Eugene Lipov, that published the first case study using SGB adapted to treat traumatic stress symptoms. And what it is an injection of an FDA-approved, very commonly used local anesthetic called bupivacaine or ropivacaine sometimes in the neck. And that's the same anesthetic that's used for women in childbirth. So it's not mysterious. The real importance in this safety protocol is in finding the physicians that really understand anatomy, because people are actually a little bit different underneath the skin in terms of their anatomies. And so having a physician that really knows how to understand the body and visualize it using ultrasound or fluoroscopy. Most of our clinicians use ultrasound now as the safest way to see the vasculature, to see the veins in the neck, and be able to make the injection exactly where they want to place it. I don't know what that was, but I'm not going to worry about it. This has really begun to pick up steam. HR 1656 is the Treat PTSD Act. It would require the VA and DoD to furnish SGB to veterans, members of the armed forces who have been diagnosed with PTS. And it's been endorsed by the biggest, oldest, most well-established veteran support organizations, the VFW, Veterans of Foreign Wars, and Vets in the American Legion. Has bipartisan support. I just met with a congressman yesterday to discuss it and ask for his support on this. So it's gathering support and will hopefully make its way through into law so that people have this option if they want it. Like I said, in 1926, SGB was first documented for chronic pain. And as I said, in 2008, Dr. Lipov published the first peer-reviewed study. It was a case study of an armed robbery victim who was headed to an inpatient unit. And this was kind of a Hail Mary. It was kind of a last attempt, but it helped him so much that he didn't have to be admitted for inpatient treatment. And this is what Dr. Lipov said about that first case. Just a direct quote. I called all of the principal investigators for some of the major studies in SGB to include Dr. Lipov, our chief medical officer, and said, break it down. Give me the quote of what did your study show in lay terms. And this is what he said. So across the board, different research teams, different groups have looked at this, and the range for positive outcomes is usually about 70 to 80%. So very high range of efficacy. Not everybody will have the response we're looking for. I am skeptical by nature and tend to think if somebody says, oh yeah, this will work in 100% of the cases, maybe that's a red flag. So this is very efficacious, but there will be some people for whom SGB is not the right intervention because it just won't have the effect. We also have an RCT, randomized controlled trial, that was published in 2019 by Olmsted and colleagues that occurred at 3 major military facilities. And that showed that SGB is a safe and effective treatment for post-traumatic stress symptoms. Lynch and colleagues did the study that really zeroed in on what types of symptoms within that PTSD diagnosis does SGB really target. And it was shown that the hyperarousal symptoms that I mentioned are those target symptoms that it seems to be very effective at addressing. And that SGB actually improves performance, not just neurocognitive function, concentration, focus, things like that, but reaction time. And this is really important because many people that we treat, first responders, police officers, veterans, they want and need to have that ability to respond if there is a threat. And so SGB doesn't remove that. It actually preserves it and allows them to respond to threats, but not be activated all the time when there isn't a threat. Dr. McLean is an active duty Army physician who works out of Tripler. He's done thousands of these. He did a large study of 250 soldiers. 100% of them were satisfied, said they'd recommend it to a friend. And 95% of behavioral health providers would also recommend SGB. These are people like myself that have seen how it works in combination with therapy. This is my patient X. He contacted me 5 years after SGB, and he said that it saved his life back then. It gives people hope. So I met Dr. Lipov here in the lower left corner on a public live television program I've worked with for many years with a crew of veterans that I'm friends with. And this program is Veterans Voices, and we had Dr. Lipov on, we had Dr. McLean on. So 2 of the leading authorities in this, both of them have done well over 1,000 procedures. And they really have seen how this is game-changing. So I show this because I'm very skeptical, and you can see it on my face. This is my really skeptical face here. And then here's a day when I actually had come into Chicago to Dr. Lipov's clinic with 10 of my favorite veterans, and they all got treatment that day. I was bedside with them, and it was just really cool because I was able to see the immediate transformation of many of their worst symptoms. They were able to smile, their faces changed, they looked relaxed, the stress lines dropped. They then went out to dinner with their wives, and their wives were texting me saying they're just having a wonderful time, laughing with their back to the crowd. Nobody's worried or anxious about anything. It's just what happened that this was possible. Just an amazing day. And Stella has a large network of some of the best docs in the country. We really have rigorous screening, and we won't work with someone who can't show us that they really know how to understand the body system and to engage in trauma care. So that's another part of our training, is to really focus on our specific population and help them to work with our specific population who have been traumatized. This is not something we're doing just for pain. It's for people that have had trauma, and you need to handle them very thoughtfully, with intention, and with a trauma-focused approach. So that's part of the training of our physician team. Our study was the largest study to date. I think there'll be larger studies coming out that are underway, but 327 patients, so a very large sample size, showed that 83% had a positive treatment outcome as defined by the National Center for PTSD, And our average outcome was 3 times better than what the National Center considers something to celebrate, a very positive outcome. Also, we have seen that SGB works for all types of trauma. In that study, we looked at, did it work better for certain types of trauma, or did it work better if the trauma was more recent versus in childhood, and saw that it seemed to work really well for people who had childhood abuse as well as more recent traumas and a wide variety of traumas. Some of our clinics offer ketamine. We are innovating in that space of SGB, ketamine, sometimes combining the two in really clinically innovative ways. And these treatments that alter the biological system and restore calm in the body really help address what I call the mind state barrier. So it just comes from really years of thinking about how I would work with patients, and they were there, but you could sort of smell their fear in the air, and you could see them being reluctant to talk about the worst day of their life, understandably. And there was just more fear than hope that motivated them. The brain doesn't operate well under stress. And so they were there, but not really there. And in that large study that I talked about, here are some of the pieces of evidence that their brains are altered. Their difficulties with concentration, thinking, memory, and confusion are part of PTS. So if we don't take care of this for people first, it will absolutely affect the quality of the therapy and the traction we can get with them in therapy. And this to me is one of those stunningly obvious things now that it took a while to put together. And I'm just trying to share that message. You have to treat the biological injury first, and then you do the therapy. It's a different equation entirely if you do. So SGB and ketamine, what they do is they accelerate. They don't replace the work of treatment providers. They accelerate, enhance, and deepen that work of talk therapists. And I'm going to have Paul talk about how that worked in a practical way when he attended UCLA's Operation Mend after getting an SGB. But therapy, as I pointed out, is so critical. You know, we still have to do the work of looking at how trauma changes us, how it changes our identity, how it changes our ways of thinking and behaving and navigating our close relationships. And so these new innovative treatments, these biological treatments, open a window of opportunity and create potential for change, but we still need to do the work with people that really understand trauma and can take us through that process of healing. And this is really, like I said, not just about a technique, a specific tool in the toolbox, as people like to say. It's actually one of my least favorite phrases, but it's so common. I just smile anytime someone says another tool in the toolbox, because I think we have to think way bigger than a toolbox. Like I would chuck the toolbox off the side of a cliff any given day and say, let's expand our understanding of what the treatment should really focus on. What is trauma? How does it change us as humans? Maybe medication isn't the first tool that we should use in the toolbox. Maybe it shouldn't be considered the best frontline treatment for trauma. Maybe there's a precision medicine treatment that is not psychoactive that we can try, that's localized, it doesn't stay in your body, that doesn't require you to take years of medications. Maybe we should think about how exposing people to the worst day of their life is maybe not the best, most compassionate way to set up treatment. Maybe they won't come into care if we propose that they talk repeatedly about the first day of their life with someone they just met, even a licensed provider. Maybe they need to approach what they would rather avoid. Maybe there are things about those therapies that are really important for people to engage in, but not until they address the biological injury. Maybe we help them get calm in their own bodies and get back that sense of self-control in their own bodies. And then we ask them to walk with us through that day of trauma. And they won't feel so overwhelmed because we've helped them with the biological injury first. Maybe therapy alone isn't enough to recover. Maybe, it's not just a tool in the toolbox. Maybe we need to think broadly about what does radical collaboration look like when providers from the pain discipline that had no mental health training do their piece and they work with and give these precision medicine treatments to patients and they collaborate meaningfully and they do it in a trauma-informed way. Maybe my role is to train all those providers and scale what I know so that they can address their patients in a trauma-informed way for their piece, and then providers can do their work in therapy with these patients. And maybe healing doesn't require years of medication and therapy. Maybe it can be accelerated. Maybe people can get their lives back faster if we put aside what we think we know and we adopt new ways of understanding trauma and its approach. Maybe healing doesn't require years of pain and suffering. So for me, this is about bigger paradigm shifts, not about tools in a toolbox. This is about how we need to think and operate from a heart level as healers, that we're not the savior, that medicine is a team effort, that if we don't do everything a patient needs ourselves, then we should advocate for patients to get those innovative treatments, and we should work with those providers, not try to own our patients and say, oh, I don't understand this new treatment or sounds fringy. I've just heard so much of that. And I think let's step back and think about who we are as healers and what it means to be brave in our own ways and accept that it's time to evolve and it's time to innovate. And maybe it's time for us now to realize the full potential of what we've been talking about in graduate school for 30 years, this biopsychosocial model. Maybe we can realize the full potential of that model if we collaborate in these more deeply meaningful ways. Maybe we need to realize that polio vaccinations and other innovations seem odd at first, and that before they become comfortable or normal, they're going to seem odd, and we need to still stay open and not be so afraid that we don't adopt the innovations that are going to save people's lives. And maybe ultimately our commitment to our patients means that our love for them, our care for them, in the sense of an appropriate kind of love, just a care for their healing, has to be better than fear and risk aversion. Maybe we have to innovate and do it responsibly in the right way with the right measures and the right supports. Maybe we need to have our care be stronger than our fear. I am losing my voice from being on my soapbox for too long a space. So Paul, I'm going to turn it over to you to share about your story. And if you could address anything really, in these paradigm shifts, as well as how SGB worked with Operation Mend, that would be wonderful.
I'd be happy to. And I get a kick out of doing this with you each month because I always take notes, and I always take different notes.
Good. I don't like to do anything the same. Never again. If I'm bored, then other people might be bored, and that's not acceptable to me.
I'm not bored. I'm never bored. So hi, everybody. My name's Paul Whitmer. I'm a Army vet, 3 tours in Iraq, 2 in Afghanistan. Like I mentioned earlier, I came back from my 4th tour and didn't really think I had a problem. This would have been circa 2008. Had a panic attack, couldn't really track it down, never happened again. And in 2011, I deployed again. Came back in 2012. I kind of flirted with the VA system circa 2008, and their response was meds. Not a big meds guy. Doc mentioned earlier about good people in the VA. I've met tons of them. There are great people in the VA. I totally agree with that. But I had a real hang up over the traumatic event clause that's so much a cornerstone of CPT and PE, which seems to be the way the VA just attacks everything with CPT and PE. I remember going to a medic and saying, hey, I can't relax. I just can't relax. I would do something, I would come home and I would be wide open. The throttle was wide open. Couldn't figure out what happened. Um, in 2018, I was pursuing a master's degree, and I was tasked with a term paper over an individual that was a hypothetical individual that was in the military and was not making any progress in CPT and PE. And why were they going to keep this individual in the military? And I stumbled over SGB. Didn't know anything about it at the time. Ended up going down the rabbit hole and really getting into the research from Mulvaney and Kristen Ray Olmsted and Lynch and Brian McLean. And man, my eyes really came open with this thing. Fast forward from 2018 to 2021, I was offered the chance to get an SGB injection, and I raised my hand vigorously to say that I was interested. I received my SGB injection from Dr. Lipov in Chicago. It would have been March of 21. So 13 months later, I'm still happy. Everything is still working. People have asked me repeatedly about how long does this last for? I've had mine for more than 13 months, and I still am feeling results. I feel normal. So I made great progress. Another thing Doc mentioned was the mind state barrier. I think that's real important. I never really got traction with any of the VA behavioral health people for years, 7, 8 years. I was going from one place to another place, and I'd try it and I didn't like it, and I'd give it a chance and didn't like it. Meds were starting this med, stopping this med. At one point, there were 7 meds going on in my system. Now I have none. But what's really nice is I found a behavioral health guy, and I'm really making good progress. I found him last year through the Road Home project at Rush University. And the SGB really gave me the chance to make inroads that I think I couldn't get over that hump. I couldn't get over that mind state barrier. And now I'm really moving through things with this provider, really making a big difference. And not only that, but after I received my SGB, a couple months later, Dr. Joe and her team at Operation Mend in UCLA, I got the opportunity to fly out there and spend a week with them and do some diagnostic work. So I had a MRI of the brain, which is something I probably would never have been able to get through the VA system. I met with some of the nation's best people, behavioral health people, and did a lot of testing. And I really came away feeling better and feeling more knowledgeable about where I was in relation to others. I kind of came away feeling I was a lot better off than I thought I was before I went. So it was a major plus for me. I came home feeling, I'm not that bad, not that bad. I'm looking over my notes here. I'm having my best interactions now with my psychologist from Rush. And I don't think that would have been possible pre-SGB. I really didn't feel good, didn't feel safe, couldn't really trust anybody. A lot of meds going on again. So I was kind of in stasis. And now I've pushed through that, and I'm really happy with the benefits the SGB has provided me. But again, it's not the silver bullet. The SGB has really given me that chance to build that relationship with my behavioral health provider. It's also allowed me the freedom to do the things that I didn't think I would have been able to do pre-SGB. One of those is Operation Mend. Leaving my home and flying somewhere and spending a week with strangers, I was not going to do that pre-SGB. That was not going to happen. Going to several of the retreats that are around the nation, stuff in the Warrior Care Network and the Warrior Connection, things like that. Never would have crossed my mind to attend those retreats. Now I'm a full-fledged member of those. type of interaction. So now I'm a mentor. So now I'm working with other veterans that are coming through. So I've really been able to open the door into some of this stuff. And Doc, I'm kind of anything I can add that I'm not touching on.
No, I am just soaking it in. No, it's awesome. Perfect.
I wanted to say something. Marjorie is in the crowd, and she mentioned something earlier about a slide that you touched on, reference cognitive. It had cognitive in the slide. It was pre Dr. Lipoff, so it was in the earlier part of the slide. So I just thought I would, Marjorie, if you're watching, maybe you can ping us when we get to that one.
Are we thinking this one?
I see neurocognitive.
Pre-Dr. Lipoff, you said. Okay, let me go back. Pre-Dr. Lipoff. Oh, this one? Changes in cognition and behavior?
I'm waiting on Marjorie to see if she'll shoot something out there. Yes, that's the one. Thank you.
Okay, cognitive is just a fancy word for PTS, post-traumatic stress, causes a biological injury and changes in how we think and behave. Cognition is just our pattern of thought. So, for example, Marjorie, if we were to previously view the world as a basically safe place, few things happen in the course of our day-to-day lives, but now we've shifted to a world where we are filtering for where the threat will come at us. And it's almost like, for me in my head, I go to the Terminator, actually, the classic movie with Arnold Schwarzenegger. And you think about in like his robot brain, he will look at different people and situations and kind of scan for a threat or an object that he's seeking. He's trying to find this kid. So it's kind of like when trauma happens, it changes our brains in that way where we have a bias towards seeking where the threat may come at us and sort of filtering the world through threat. So it's just those changes in how we think and behave, as well as our identities and our relationships, are what I was emphasizing that we need to focus on, not just get calm in our own bodies, but actually do some focused work on those things as well. Did you have a specific question, Marjorie? Because if you did, feel free to put it in the chat if you want.
Thanks for going back to that, Doc. Appreciate it.
Yeah, of course. Okay, does anybody have any other questions for us before we wrap up for today? Let me give you guys the contact information here as we're closing out. Here are some key contacts within Stella for if you want to look at the treatment for yourself or refer somebody who might benefit from this. There's a lot on the Stella website. You can go as deep as you want. I wrote a 35-page white paper that's on the website. It says download our free white paper, and you can go into that and read up on a lot more than we shared today. This is kind of an overview. If you're a partnering organization or if you're a clinician who wants to treat the patients after we provide SGB, we have a free SGB educational series. So kind of like this, but it's in short videos, 10 or 15 minutes each, no charge. Everything's free, and we just got it certified, I understand, for social workers. So you can get even free CEUs if you're a social worker. We're working on some of the other boarding processes. It's a long process, but won't cost you anything. It'll give you great information about how to prepare your patients well for SGB, what some of their common concerns are. If they don't respond, what are some options, things like that. And you take that, you take a quiz, and then you become qualified to accept referrals from Stella and be added to our Stella provider network. How much does it cost? The cost, first of all, is not covered by insurance. We're hopeful that it will be within the space of 2 to 5 years. insurance is often slower than innovation. It does vary by state. And so depending on the geographic region, there can be some variation in cost. But the range of costs is typically about $1,600 to about $3,500, depending on the location, the region, the market, area where the treatments occur. So for example, just like everything in California, including gas, is more expensive out here than someplace, for example, in the South or the Midwest. It'd be more expensive typically in California than in some of the other locations.
Hey,
But
Doc,
also, yeah, go ahead.
I'm sorry.
No, go
Uh,
ahead.
Marjorie asked, how long does an injection last? Are there a series of follow-ups or is it a one-time deal? And then she asked me, did I need subsequent injections? And I did not, but I'll turn it over to you, Doc.
Paul is in good company. Many people don't need subsequent injections at all. I've had several patients that have had one dual injection and been good for years. The thing that I think matters here, and there's a number of things, and I would boil it down to three major factors. The first is what kinds of trauma and stress happen in your life after the injection. So I've had patients that have gotten calm and done really well for a while, and then had another major stressful event, and their bodies responded to trauma like anybody's would. And so depending on your environment and your future stress, that can be a factor as far as whether you need another injection. The second thing is what you do with the opportunity to reset. So if we have people that just get the injection and they don't change those cognitions, those patterns of thinking and behaving, often they fall back into the same patterns or end up kind of self-sabotaging or creating more stress in their lives. And then they may find themselves back where they were. The other factor is the biological differences that we all share. So for those, 10 to 15 to 20% for whom it doesn't work, I don't think we know why it didn't work for them. So there's just some biological differences in how people, I think, are wired and how they carry stress. And the same can be true for longevity of results, but it's typical for this to last for 6 months to many years from a single or a double 2-day injection procedure. Often at Stella, what we do is we will give a serious discount on the second injection if people need a second injection as well. And as far as cost, I should also mention that we have a partnership with Care Credit, where people who can't afford this, often they can afford it if they were able to pay it off in little chunks over time versus one big lump sum. And so Care Credit is a company that does not charge interest, that allows people to afford this until such time as hopefully insurance starts to take care of people with reimbursement around this.
Awesome. Can I throw one more thing in, Doc?
Yeah, always.
And this is sort of an unexpected benefit of SGB to me personally. I don't know if it applies to others. I'm quite confident it probably does, but alcohol consumption. My alcohol consumption post SGB dropped off dramatically, to the point where I think I went several months without alcohol. I just became so comfortable that it turned around and looked, and what were you doing all this drinking for? And I think it was an effort to, subsidize my anxiety and kind of keep it intact. And that's what it did. It kept my anxiety intact. It didn't allow me to move through it. After the SGB, I didn't need that crutch anymore. And so, I still consume alcohol. But I really don't feel bad about it now. I don't feel like it's being used for something other than just, get done mowing the yard, have a cold beer. So now I kind of feel comfortable in it, whereas before I really didn't. So that really benefited me, and it benefited my family. So I'd be I want to make sure I got that in.
That's awesome. No, thank you. I've actually had several patients say the same thing, that they just lost their taste for alcohol, or had people, again, depending on what you do with the opportunity for a reset, had people quit smoking as well, and using other substances in that window of calm and just feeling well in your own body for the first time in many years has allowed many of my patients to stop smoking, stop drinking to excess, stop using other drugs. That was one of the things we talked about with the congressman, because this particular congressman really cares about substance abuse in our country. And this has been such a common thing that patients have reported back to me, just as you shared, that it's critical for some people in helping them to change that that dependence or use of substances. So thank you for including that. All right, well, I guess that's it for today. Thank you everybody for joining us. And we made a video, I think, as we always do. So if you have friends and colleagues that would want to see this talk Paul and I gave today, then let us know and we can send you a copy of the video. Thank you as always, Paul. I always enjoy this. Guarantees we get to hang out at least once a month. So thank you for doing this with me.
I'm in the midst of my new book, Relentless Courage, and I'm really enjoying it.
Hey, cool. Yeah, I just he's talking about my new book that I just wrote about first responder trauma with Michael Sugru, a retired sergeant. And I'll tell you a quick little story, or if we're all still here, it's just kind of fun. There's somebody in the book that just got out of prison. He was in prison for a very long time for something really bad that he did that made the national news, and it really hurt my friend Michael. And it was scary to me to write this book about this person, because this is the town where I live, and he had done these things, and then he had posted on Facebook publicly that he just got a copy of the book, and I was really, my blood pressure went up a little on that one. And over the weekend, he issued a public apology and an acknowledgement for what he did in the past, and said that the book was wonderful and he was so proud of it and appreciated all of the insights that I shared and Michael's courage in sharing his story. And he acknowledged and apologized for what he had done. And it was just so cool. Such a relief for me to see that happen, and to be able to bring that healing and repair to that relationship, or at least forgiveness and just peace in that relationship. And to know that, he saw the true reason why we wrote the book is not to go after anybody, but to really explore how trauma impacts all of us. And so I wouldn't be surprised if this man and I at some point meet up, and maybe he'll even do some interviews with me, and kind of I can maybe help support him a little bit in some way along his path, which is to use his experience to help bring people out of dark valleys as well. So yeah, really cool. I just got my book yesterday, actually, and everybody got it before me, which is typical.
I,
So thank
I'm
you,
gonna,
Paul. I can't
I,
wait to get your review when you're done with it, see how you felt about the whole book.
oh yeah, and I'm going to assume you were talking about a gentleman with the first name of Norm.
Yeah.
I
Yep.
I got it. I got it.
If
Okay.
you go on Amazon, he even posted a public review, a 5-star review of our book. That's the person I'm talking about. So really just such a wonderful outcome on that, and so relieved that he had the integrity to show up in that way. But thank you for getting a copy of my book. It's called Relentless Courage, if any of the others of you are interested in first responder trauma.
And I see where Kevin has asked for a copy of the video. So could you explain how he can track that down? And
Sure.
I also see a note here, an email from Marjorie. I don't know if there's a chat box open to you, Doc.
It looks to be. I have an email here. So yeah, I am Doc Springer, DOC SPRINGER, Marjorie at stellacenter.com if you want to send me an email. And for the other person, Kevin, I think you said, if you reach out to Penny, PNNY at stellacenter.com, or me, Doc Springer at stellacenter.com, ask me to send you a copy of the video. I'll pump it over to you in an email. Yep. Thanks, Paul. Appreciate it.
You bet.
All right, everybody. Have a good day.